Hello, it's really great to have you join us today on this short video on primary biliary cholangitis. My name is Gideon Hirschfield and I am a hepatologist from Toronto. I am joined by Professor Marlyn Mayo from UT Southwestern, who's also an expert on primary biliary cholangitis. What we're going to do today is have a conversation, particularly focusing on symptoms and PBC. So, hello Marlyn.
Hi.
Thanks for joining me today. Today, I think the audience would really like to gain from a lot of your experience on the management of symptoms in PBC and your experience of actually measuring those symptoms. So I've got a few questions. I'd like to start off with, why are symptoms so important for people living with PBC?
Well, I think, you only have to see a few of these patients in your office before you realize that the symptoms is really what drives their well-being. As hepatologists, you and I both monitor their disease activity with blood tests and their disease stage with, elastography and biopsies. But they don't feel that on a day-to-day basis, right? They don't feel that their alkaline phosphatase is 150 or 250. And so it doesn't really impact their daily life. But it's the symptoms, the fatigue, and particularly the itching that really drive how they feel from day to day.
And just to summarize, what would you say the symptom burden is in PBC?
It's actually much larger than most physicians realize. And we know this from various symptom surveys that we've done in large populations of patients with PBC. It is the vast majority of patients, over 50%, that will suffer from itching and fatigue.
And what would you say the impact of symptoms are for patients beyond, as you say, the concept of disease progression?
Right. Well, it's honestly quite variable, right? So some patients will have, some will have no symptoms. Some will have very mild symptoms, and for some, it's absolutely disabling and drives their entire life. Prevents them from working, prevents them from sleeping, is truly disabling. And I think one of the frustrating things for symptoms like itching and fatigue, which are the primary symptoms with PBC, is it's hard to convince other people how disabling those are, right? So it's very different if you have a musculoskeletal issue. People are very quick to realize that that person must be disabled, can't work, needs a handicap placard for their car, etc. But when you take someone who's so exhausted that they can't, walk from their car to the store, or itches so badly that they can't go into the office and work a full day, it's hard for those people to convey that to other people so that they understand what they're going through.
So on that, I think maybe I could then ask you a little bit about your work that you've done in developing tools to measure symptoms, particularly itch. Because I think we'd be interested to know, why and how, and your role, for example, in the 5D itch score and how to actually measure something like itch.
Right. So the 5D itch score, as you referenced, was a scale that we came up with some years ago. It started off really, we were in need of a clinical trial tool. We were going to be conducting a clinical trial, and we needed a measure of itch that was very responsive to change. There had been measures of itch out there, visual analog scales and 1 to 10 scales, but there was not sufficient data that that these scales were responsive to change. And so I don't know how much the audience knows about creating, questionnaires and scores, but the first step is that you sit down and really have open-ended conversations with patients, ask them how they describe the symptom and what matters to them. And so when we went through that step, we found that there were many aspects to itch severity, and just assigning an intensity number of like 1 to 10 did not do it justice. For one, itch varies in intensity throughout the day. One person could have 10 out of 10 itching for 5 minutes and feel fine for the rest of the day. And another person might have 4 out of 10 itching that lasted the entire day. And which is worse? That's hard for us to quantify. And also, similarly, one person might have an isolated itch on the back of their arm, and another person might itch in 40 different places all over their body. And which of those is worse? And then in addition, we also found through that interview process, just like our colleague, Dr. Jones, that the impact on their life that the itching has has a profound effect on their perception of the severity. So the more disability it gives them, the more severe they think the itch is. And this is highly individualistic. One person might be miserable because they itch all night long and they can't get a good night's sleep. And another person might be, a clothing model and they can't work because their clothes are too itchy. And yet another person may itch all day long, but they're retired, they stay at home, and they don't seem to suffer too much disability from it, even if they do feel miserable. So all these findings came together for us to create this multi-dimensional tool. It's called the 5D because it assesses the degree, the duration, the disability, the direction, and the distribution. And we felt that best encompassed and best measured what the patient was going through.
That's very helpful. And I mean, obviously 5D itch has largely been used in clinical trials. What do you do though in your daily practice when you're assessing symptoms for your patients living with PBC? And what advice would you give to, physicians who maybe have less PBC patients because they have a more general program as to how they should be assessing something like itch on a day-to-day basis?
Right. Well, as you mentioned, I mean, the 5D was created specifically for use in clinical trials. Not that it couldn't be used in the clinic, but let's face it, we are all very busy. And you don't have time to sit down with a patient and go through usually even 5 questions in the office. If you're going to use the 5D in a clinical scenario, it works best if you give it to them ahead of time, like as a sort of a pre-read or a pre-task before you come to the office. But honestly, I don't even do that. I think the most important thing when a clinician sees a patient with PBC in the office is, number one, just ask, do you have itching? And honestly, a lot of physicians don't do that. We've done studies, others have done studies looking at how often physicians ask. If you look at how often it's in the medical record, it's only about 20% of the time. But part of that is maybe they asked, but the doctor didn't write it down, or maybe the doctor didn't ask at all. But if you ask patients, over half of them say their doctor never even asked. So the most important thing is just ask any way that you can, do you have itching? What I do in the clinic is if they say yes, I have a very short series of questions. I say, how bad is it? Can you rate it from 1 to 10? Just a simple 1 to 10 scale. And then does it interfere with anything in your lifestyle? And then the third question is it bad enough for you to consider taking medication? And I find that those 3 short questions, how bad is it from 1 to 10? Does it interfere with anything in your life? And is it bad enough for you to take medication? Usually gives us direction, gives me a good sense of where they're at and what they want me to do as their physician.
Okay, that's very helpful. And then you'll know that a lot of the clinical trials that are now being presented are measuring symptoms such as itch. How do you recommend GIs interpret the data? How do they know what is a meaningful response in a clinical trial, either using as you say, a 1 to 10 scale or something more complex like a 5D itch? What should they be looking for? What change means something for patients?
So that's a really good question. As you said, there are more and more studies for PBC that are looking at itch as both a primary or a secondary endpoint. And many of these are starting to show a positive effect. I think probably the most important thing to consider when you're critically evaluating that literature is there a placebo arm? Okay, so you must have a placebo arm because placebo effect can be very large for an itch, and it's typically around 20%, but it's also not very well sustained. So you can get by on placebo effect for so long, but eventually, it wears off. So I think the other important thing is to look at the length of the study. So if you have a study that's only a few weeks long, and the drug effect is, less than 20%, that's a finding that I think would need further validation. I think another thing to consider when you're critically evaluating that literature is, even if you have a placebo-controlled study, if the drug that you're giving has a predictable effect or a predictable side effect. So for example, if that drug lowers alkaline phosphatase and the patient sees their alkaline phosphatase, or that drug causes diarrhea and the patient knows that as well and gets diarrhea, keep in mind that those patients are probably effectively unblinded. And I think that's an important bias to look for. I think another important thing to look for is not just the itch severity on a 1 to 10 scale, but also to look that the study has evaluated the impact of the itch with some kind of quality of life score, whether that be 5D, PBC 40, other quality of life measures, because as we discussed in the earlier question, itch is really multidimensional, and what matters to the patient is the impact of the itch on their life.
So on that point, can you tell me about why we should also be looking at sleep? Why would sleep quality and improvements in itch be a relevant thing to look out for?
Right. So itch can cause disability in many ways. So as I mentioned earlier, it might interfere with your ability to work. It might interfere with your ability to sleep. It might lead to social isolation, because people are worried about their skin lesions, or they are fearful that they might be viewed as contagious somehow. So there are different ways that itch can cause disability, but the one that is the most consistent and the most prominent is the impact of itch on sleep. And maybe that's because the PBC itch tends to be worse at night. But it's very clear that sleep and itch are tight bedfellows. I think there's a pun in there somewhere, but they have this codependent relationship. And in the itching at night prevents sleep, and then you get exhausted from lack of sleep, and that worsens the impact of the itch. And we now actually have hard data on this, from some of the IBET inhibitor studies that show that if you improve itch, that is associated with an improvement in sleep. And so asking about sleep is a powerful way to determine what the impact of the itch is.
Okay, that's very helpful. So I think, we've just come from ASLD, and we'll eventually next year we'll be going to EASL. Just to end then, Professor Mayo, do you have any expectations of what sort of things you'll be looking for at EASL 2024 on PBC?
Well, I don't know about expectations, but I certainly have hopes. Um, with respect to itch, I'm hoping that we're going to see some of these phase 3 and even phase 2 studies looking at IBAT inhibitors, which should be completed by then. At the ASLD meeting, we saw very exciting data from phase 3 data from the PPAR agonists, and their effect not only on the underlying disease, but also on itch. And so I hope that in the upcoming EASL meeting, what we're going to see is some deeper analyses of these PPAR agonist studies, with respect to itch, some of the biomarkers that are associated with itch, evaluating, autotaxin levels, IL-13 levels, bile acid levels, how those tie into their effect on itch. with respect to the PPAR agonist effect on the underlying disease, we really just heard at AASLD kind of top-line biochemical results. So I'm hoping that at EASL, we'll see some of the more in-depth analyses of fibrosis progression, perhaps some elastography data, serum fibrosis markers, additional symptom analyses to see what effect some of these new therapies under investigation might have on fatigue. I think there's a rich list of possibilities of what we might see at EASL. And so I'm really looking forward to what actually turns up.
Well, that's great. It's been really fantastic to talk to you today, Professor Mayo. It's been very insightful. I think you gave some really good advice, both, on symptoms and the burden for patients with PBC, but also on the challenges of measuring it and what you should be measuring it. So with that, I'd just like to say thank you. And I agree, I'm also very excited for EASL 2024. Thank you very much.
Thanks, Gideon. I appreciate you having me today.